Good morning / afternoon to everyone here. Our next speaker is the Dr. Tony Rodrigues. He co-developed and is the director of MEDFEM, Fertility Clinic. He has also co-authored the book Faster, Better, Sicker, Time, Urgency, Perfection, Stress. He's also co-developed Staminogro, a natural product for fertility and general health. He's also co-developed an online self-help interactive stress management program. Let's give him a round of applause.
Thank you, everyone. Before I start, I would just like to share a word of thanks to FASA. There we go. You know, when I first heard of the concept of this day about, last year sometime, I think, I wasn't sure that it would be successful. My wife, who's our clinical psychologist, who's sitting here, said to me, it will be successful. So that my mind then changed to it will be successful. And to be very honest, and I'm sure you agree, all the people sitting here, maybe we can give, in fact, the whole group who've organized this a bit of a hand. It is unique to have a whole team of people, both at a technological level and at a different practice level, being in one spot, sharing information and sharing with all of you. I've always been of the philosophy, although there's a lot of units in South Africa, we are really have one goal in mind, is that everyone who visits us one way or the other should have a baby. And I've done this for 30 years, so it's, and I know all my colleagues at different clinics, that's their sole goal. So although we are in inverted commas in competition, our goal is the same, as to help you all. So I was asked to talk about natural cycle and mild IVF. It is relatively simple, and I'm going to take you through it. It'll bring up some of the things that happen in IVF programs anyhow, and then there's plenty of time for questions. So the first thing is to understand is there's certain indications for IVF, and you don't have a choice in those. The top one is where you have tubal disease, and the tube could be blocked at the end of the tube, over there. It can be blocked where the tube goes into the uterus, or you could have had a previous sterilization. Generally, in tubal disease these days, in modern tubal disease, we tend to do IVF as opposed to repairing the tube. Repairing tubes doesn't give you good results. Having said that, if you've had a reversal, there are still a few doctors who are really good at reversing previous sterilizations if a clip has been put on the tube and it hasn't been cut. The other importance here is if you have a blocked tube at the end of the tube like that, remember that if that is found in any of you, that tube needs to be removed. So if you've got a blocked tube there, it fills up with fluid. That fluid goes down the fallopian tube and it actually kills off the embryo. So if any of you have that, the doctor will, or you're with a non-fertility specialist, it plays a role. And there's a group of women who've got one tube blocked on one side and a normal one the other side. And as soon as you remove that old damaged tube, you no longer get the killing of the embryo in the natural state, and they fall pregnant naturally. So it sounds terrible removing a tube, but a tube does nothing other than allow the egg to pop into it, and the egg sits at the end of the tube over there. The sperm then goes all the way up to that egg, fertilizes it, and it spends another 5 days going down, 5-6 days down into the uterus. And in IVF, when we do our transfers at MEDFEM, we always do day 5 transfers, and basically because that's the time that the little embryo would be in the tube. So tubal disease needs IVF. It's an absolute indication. If a male has very low sperm counts, where you cannot, it will not fertilize naturally, or if the sperm has problems with antibodies, where the male has developed antibodies, often related to trauma, playing cricket, being hurt on a bicycle, those things cause damage to the testes and can cause antibodies. that group of men, or if you have to go and get sperm from the testes, that group of men will have to undergo, the sperm will have to inject the sperm into the egg. It's an absolute indication. There is no other treatment other than using a donor, obviously, but if we're going to use that sperm, you have to do IVF. And then there's this group of patients, and you've just heard about polycystic ovaries, who have resistant polycystic ovaries. No matter what medication you give them, so you start off with oral treatment, and that doesn't work, and you go on to injectables, and you just can't get them to make 1 or 2 eggs. And the principle of our work is we're making 1 baby. That's the message. The 2 baby thing does happen in IVF. It happens because we put 2 embryos in some people. It's not the object, and there are higher risks with twins. We can manage those risks, but we definitely don't want more than 2 babies. And there's a group of patients that if they've got resistant polycystic ovaries, and the only way to get eggs from them is to actually have a lot of eggs. So in that group needs IVF. And the reason that's not an issue anymore, because we can up the dose, they can make 20 eggs, we take all the eggs out, and they're not going to have 20 babies. They're going to be controlled 1 or 2 babies. Okay. So the reason I'm bringing this up, and it'll come back to you just now, when there are absolute indications for IVF, the important thing there is that group of people, we mustn't judge the egg reserve in that group of people, because that lady hasn't had any chance of being pregnant. So we don't know the quality of the eggs in that group of people. So if someone's got a low egg reserve in this group, they can do well making 1 egg, because they might have a great 1 egg and it's never been tested. If you've had blocked tubes forever, if you've never ovulated, and you've got a husband who unfortunately has a low sperm count, you've never tested the quality of your eggs. So we see it as a very positive group, even if a woman has very low egg reserve. And that's part of the talk that we're doing today, mild and single egg IVF. Other indications for IVF, if you've had inseminations for any reason, and you have repetitive failed cycles, our particular unit, I'll go back there. If we're doing IVF inseminations for whatever reason, and we go beyond 3 cycles, we have to have a very good reason to carry on. And in some patients we would, because you're starting to drop those rates. Endometriosis, again, you heard the talk earlier. If a patient has severe endometriosis, often that becomes an absolute indication, their tubes are not right, etc. But other endometriosis patients, if you have recurrent failures of your simple techniques, you will have to do IVF. We do put a lot of emphasis on what we call cervical mucus. Cervical mucus is the mucus that's made during ovulation. It usually kicks in on about day 8 in a very fertile woman, and goes on to about 36 hours after ovulation. It's probably the biggest cause of infertility that we see, and a lot of the patients in that group also have some form of polycystic ovaries. The problem with mucus, it's like having your natural contraceptive. It's like having something that every time you have intercourse in someone who's got a good ovulation, good uterus, you've cleaned up the endometriosis, the husband's sperm's perfect, but it's not going anywhere. So you could argue, why don't you just put it in the uterus? The problem in that group, often the uterine environment, the uterine environment is also not good, and the tubal environment is not good, and you'll end up having to go through IVF. Now, this big thing about reduced egg reserve, and the test that you have done is called the anti-Mullerian hormone, or AMH, and it's a level of giving you an indication of how many eggs are left in the ovary. If you look at the left one there, you can see there's plenty of those little primary follicles on the left. The middle one has less, and the right one has almost nothing. So if we do full IVF on this patient here and give them high doses of drugs, they're going to make 1 or 2 eggs. So why are we giving them all these drugs? And we are of the opinion at MEDFEM that if you do that, you're actually overdosing those eggs and you're creating poor eggs. So we know from that level that that patient's going to make 1 or 2 eggs. So let's get 1 or 2 eggs and create an environment for the patient in terms of health, lifestyle, stress management, eating properly, getting cigarettes away, getting your diet right. Critical. Do all those necessary things. Get the thyroid right, insulin right, prolactin right. Make sure if there's endometriosis it's been managed. And then go ahead and aim for 1 or 2 eggs, especially in the patients who had that absolute indication where they have not tested their eggs. You cannot predict it. There are women of 49, 50 having babies naturally in the world with their own eggs without a fertility problem. How can we judge an egg that's never been tested? So what's the norm? Hyperstimulated IVF is the norm, in our opinion, if you have a normal egg reserve. And why do I say that? The object of it is to get 10 to 15 eggs. And that's not the discussion, but I just want to take you through so you understand the difference. You want to get 10 to 15 eggs from that. You want to fertilize all the eggs. You want to get as many embryos as possible. And the pregnancy rate per aspiration. So because you've got a lot of eggs, the pregnancy rate per the times that you've removed those eggs will be higher because you'll have more embryos. And just to put it in at this moment, embryo, if you don't fall pregnant with IVF, the majority of the time, if you've been worked up properly and had all the necessary investigations, and we know that it's not your immune system, and we know that your uterus is all right, and we know that your environment's all right, then at the end of the day, my train of thought went for a second there. I got a 10-minute signal there, and my train of thought went. So just to announce, I got 10 more minutes. Okay. Pregnancy rate per aspiration is higher because if I've got 6 embryos and I'm putting 6 embryos back in time, I'm going to have a better rate. So your cost for that at the end of the day is actually lower than doing recurrent small IVFs. But let's go through the mild stimulations. I'm not going to go through all of that, but you can say, yeah, it's just quickly, we've said it, resistant polycystic ovaries, male factor, absolute. If you've got enough eggs, it's better to have the numbers. By having numbers, you've got better choice, and by having better choice, you've got a better result for that one aspiration. We would like everyone to fall pregnant with one aspiration, obviously. It's a goal that we want. It's not nice to have failed IVFs. But if IVF fails, it's mostly the embryos. So if you have more embryos to put back later, that's great. So when do we do mild IVF, and what does it mean? So if you've got low egg reserve, like I said, we're going to use either low stimulation, don't aim for a lot of drugs, don't overdose the egg, or we'll do natural cycle IVF, and we'll go through it in a few seconds. If you have a low number of follicles, if you go through a high dose stimulation and there's only 2 or 3 follicles, 4 follicles, and you get 1 egg, why are we using high doses? Cut the dose, don't overdose the egg, and you will get a better concentration of eggs. And the last one, if you're getting poor embryos, so sometimes you find that you're giving these dosages, you get a lot of eggs but no normal embryos. And in that group of people, especially in polycystic patients, we've realized that you need to cut the dose, bring it right down. Even get 2 or 3 eggs, you have a better chance of getting a normal egg in that group of people. There's also a low-cost IVF, and I've got nothing against this. Some units are doing that, where they'll say to the patient, we're going to do a low-cost IVF, we're going to give you some oral medication, we're going to aim for 2 to 3 eggs, we're going to get 1 or 2 embryos, we're going to usually transfer on day 3 because you don't need to keep it in the lab for another 2 days, and we're going to put it back. So your costs in terms of drugs, in terms of not having to go through an extra 2 days in a laboratory, which costs a lot of money. To grow 2 embryos in a lab for 2 more days, there's a big cost to that in terms of the culture medium, in terms of what's going on. And I believe that's not a bad option, especially if you've got what I call absolute indications, where you haven't had those eggs tested. So the problem with that, you don't have a backup and you'll have to go through another cycle later. But so long as you've been counseled fine, there's no harm to that. It's not something we do routinely, but it is offered, and I have no problem with that with some units. So what happens with mild dose? Well, effectively, we're just cutting the dose. So we're aiming for 2 to 6 eggs, and that's what we will normally get. We know that we're not going to get numbers, we're trying to get quality, and at the end of the day, that group of patients actually do well. If you're using oral medication, if you begin getting oral medication, which is usually Fertility or Clomid, and you have it for more than an extended period of 5 days, let's say it's used for 10 days. If Clomid's used for more than 5 days, then the embryos need to be frozen, and that's the only message there, because it messes up the lining of the uterus. Also, if you're using Clomid for more than 3 months, it needs to be you need to take a break. I'm not talking about this now. This is not for IVF. I'm just generally mentioning it. You need to take a break because it messes up the lining. So 3 months, you should take a break for a month. We tend not to use Clomid. We tend to use letrozole or Femara, but it is a drug that's used by doctors. Natural cycle IVF, this is for patients who have previous poor results in hyperstimulated or mild cycles. So all the things we spoke about, if you can't get a good egg, there's still the option of a natural cycle IVF. Again, very good results if there's that absolute indication where you haven't had the eggs tested. And how do we do it? First of all, it can only be done if you've got a natural cycle, if you've got absolutely normal physiology. Does the egg develop properly? Is the uterus developing at the right time? Do you have good mucus at the time of that? Are the hormones right? And we can see that physically by doing a scan on you. So what happens, we look for the follicle. You can see the big black circle, that's a dominant follicle. We want a lining of the uterus that looks like that. That's called a triple line. It needs to look like that. It needs to be above 8 millimeters. We pay attention to mucus in the cervix. It's a very simple technique. You give them a trigger injection like any other IVF. They come in and see us about half an hour before the aspiration or egg retrieval. We make sure that the egg hasn't released. Because it's a natural cycle, we do use a trigger. And the reason that trigger happens in all IVF is to release the eggs into the fluid. If you don't trigger, then it won't release, and we can't get our timing right. So we do give an injection, but they could release on their own. They could self-trigger a few hours before we give them the trigger. So we do the scan. If the egg's not there, we bring them back a month later. This kind of treatment works well for the right patients. And we've had a lot of babies in our time who've had natural cycle IVF for very good indications, and they've created their babies. And at the end of the day, it is a worthwhile thing before you give up. And again, I'm going to make the message from my point of view, our point of view at MEDFEM, low egg reserve doesn't mean you can't have your own eggs. It doesn't mean that you have to do donor eggs. You need to exhaust these things, and it's given a lot of people. It's very psychologically difficult because they might come there and it's released itself, or when you go in, there's a 10% chance that'll be an empty follicle. Does that mean there's something wrong with that patient? Absolutely not. People don't fall pregnant every month trying the first time. In fact, the average time to pregnancy under 35 is more than 3.5 months. And it's that because the other months, the eggs were not good. And the embryos were abnormal and they were kicked out. So nature, mostly in humans, makes poor embryos. And you've got to wait for the right one to get the outcome. So in summary, natural IVF, very simple. You do a scan, you give an injection, you bring them in, you take out the egg, and the rest is the same. We grow it always to day 5. In our practice, we grow to day 5. If it doesn't make day 5, we're very confident of our culture techniques, then there's something wrong. And I'd rather know there's something wrong than put it back in someone and they're not pregnant. But that's just a personal thing for MEDFEM. Modified natural, we sometimes add in some medication with the natural, so we'll see them on day 8, add in some injections just to get control of the ovulation. Mild IVF, you use low doses, you're aiming for 2 to 6 eggs, and then your hyperstimulated IVF, you full dosage, and that's the recommendation generally if you can, from an affordability, if you're going through IVF, in the long run, have the numbers, have security, have frozen embryos. If you fall pregnant the first time, you've got your frozens for the next time, and that's my talk done. So happy to answer any questions.